Hi, I'm Chris Douglas, and I'm talking about my QI project for the summer. A little bit about me. As a wound care nurse at Penn State Health Holy Spirit Hospital, I treat many kinds of wounds, including pressure injuries. Our department monitors pressure injuries regularly, keeping track of these patients who are admitted with a pressure injury and those who develop pressure injuries while in the hospital. When they develop them in the hospital, those injuries are known as hospital-acquired pressure injuries, or otherwise known as HAPIes. We report on HAPIes weekly to administration, and of course even one HAPI is too many. And administration has even lately formed a task force to try to find ways to decrease their incidence at Holy Spirit. This is why I have chosen to do a QI project on preventative strategies to decrease the incidence of HAPIes at my hospital. So what does the literature say about pressure injuries? Well, 2.5 million patients in the U.S. develop pressure injuries every year. And although they can occur anywhere on the body, the highest incidence occurs on the sacrum, and the second most common is the heel. HAPIes are linked to increased rates of readmission, increased mortality for patients both in the hospital and also out of the hospital. And also, they are very expensive to treat, with the cost ranging in the hundreds and even thousands of dollars. And I would imagine being treated with something like a high-tech wound care, such as a wound vac, could probably get into the $100,000, depending on how extensive the wound and how long the vac is on. Presently at Holy Spirit Hospital, the Braden scale is built into the electronic medical record of each patient and is completed daily by the bedside nurse. If a patient has a score of 14 or less, which indicates that a patient is at moderate risk for breakdown or worse, an automatic consult is forwarded to me and my two other colleagues in the inpatient wound care department for follow-up. So ideally, a wound care nurse will see that patient within 24 hours and put in place routine pressure injury prevention orders, including such things as an appropriate support surface, orders to turn and reposition, orders for heel suspension, and preventative skin care, especially in the case of incontinence. Prophylactic dressings may be ordered by wound care staff and include preventative dressings for the sacrum and heels. They protect bony prominences and prevent friction and shear. That's the goal of those dressings. And if wounds are actually present, we, as the wound nurses, order appropriate dressing orders for the wound, and we enter all of that into the EMR after we do the wound assessment. So once identified, the at-risk patients are then followed routinely by a wound care nurse. We'll see them like weekly or even 2 to 3 times a week, depending on the patient, until discharge, to allow for continuity of care and pressure injury prevention. But at times, the wound care team cannot see the at-risk patients with the low Braden scores in a timely manner, and depend on the bedside nurse to assess and implement nurse-led interventions to prevent pressure injuries. So a problem that we've been experiencing at Holy Spirit is that whenever a high-risk patient's not being able to be seen within 24 hours, such as a patient whose consult comes like on a weekend, or for some reason a holiday or something like that, and it may take a couple days before we see the consult, the patient sometimes found to have developed a HAPI due to the delayed prevention interventions by the bedside nurse. So this problem is what has led to my current QI project. My strategy for my capstone is still in flux. I'm trying to discover an effective way to help staff to recognize the need for and availability of preventative skin and wound products to help decrease our incidence of HAPIs at Holy Spirit. So this can vary in different ways. I haven't decided what I'm going to do yet specifically, but it can vary from verbal education to written education, visual reminders placed in supply rooms, or even as far as a change in the EMR. I feel that a QI project focused on decreasing HAPIs would be desired by our organizational stakeholders. But a barrier I can see to the project, several barriers include staffing levels. I know all hospitals are dealing with that because of COVID, and staff turnover, which is very high in our hospital. The stress of the pandemic, which has led to exhaustion, burnout, low morale for many staff. So I can see those as barriers. When it comes to timeline, I would like to have several months of pressure injury data to determine effectiveness. So my timeline would tentatively be the summer term from May through the end of July. Thank you.